In the earlier classes, we talked about the frontal, then maxillary and sphenoid sinus. And what is remaining now? It is the ethmoid bone and the ethmoid sinus, isn't it? This ethmoid bone is a very fragile or very delicate and very small bone, and it is very difficult to get it intact from a cadaver specimen. But in life, this ethmoid bone is a master controller of all other sinuses, and it is situated in the midfacial region, and it contributes to the molding of the anterior cranial fossa, the nasal cavity, nasal septum, and also to the development of orbit. So today we will talk about the osteology of ethmoid bone and also the ethmoid sinus. Okay. And we will deal with the parts of ethmoid bone. The air cells, named air cells are there. Then the anatomy and orientation of middle turbinate, the roof of the ethmoid complex along with the anterior ethmoidal artery and its clinical significance. And this ethmoid bone is a very important, very much important, both for examination and for clinical purpose. For exam, all these can be asked as separate short notes, or as such an essay can be asked from ethmoid bone. And for clinical purpose, without knowing the anatomy of the ethmoid bone in detail, never attempt to do a functional endoscopy sinus surgery or any endoscopy nasal surgeries. And it is a master controller. I said it's a master controller because the frontal as well as the maxillary sinus depend upon the drainage or the normal anatomy of the ethmoid prechambers. Why? I already told in the class on frontal sinus, I told the frontal sinus drains into frontal recess, which is a part of ethmoid bone. And also the maxillary sinus drains where the maxillary sinus drains into ethmoid infundibulum. Remember our class on maxillary sinus. So ethmoid infundibulum is actually a part of ethmoid bone. It is determined by ethmoid bone. So any variations in the normal ethmoid anatomy can lead to the precipitance of frontal or maxillary sinusitis. Okay, so this ethmoid sinus is very much important, right? And regarding the parts of ethmoid bone, broadly we can divide the ethmoid bone. Before that, how many ethmoid bones are there? There is only one ethmoid bone. Okay, this is one ethmoid bone. Or there are two parts of a single bone which are connected together by a horizontal plate. But there is only one ethmoid bone. Right? Okay. And we can broadly divide this into a vertical part and a horizontal part. Like this, a vertical part and a horizontal part. Okay. And in the vertical part comes, this part is the crista galli. And this part, this is the perpendicular plate of ethmoid. Right? And the crista galli is projecting into the anterior cranial fossa, in the floor of anterior cranial fossa, and on two sides of the crista galli there lies the olfactory bulbs. Okay. And this perpendicular plate of ethmoid is projecting into the nose, and it is articulating with the nasal spine of frontal bone, then what, vomer, and posteriorly with the sphenoid bone. Okay, so in the vertical part comes the crista galli above and the perpendicular plate of ethmoid downwards. Yeah, that is into the nasal cavity. Okay, then in the horizontal part. In the horizontal part comes this part. This area is the, which part? This is cribriform plate. Okay, that is a cribriform plate. Here. There are so many small holes in the cribriform plate. Cribriform means, word meaning is porous. So there are so many small porous areas or small holes are there, and through which what all things, olfactory filaments from the nasal cavity go to the olfactory bulb, and also the anterior vessels as well as the nerves, they come to the nasal cavity through this. Okay. The ethmoid bone is very delicate, complex bone, but very important one, and it has got a vertical part and a horizontal part. Of the vertical part, this is a perpendicular plate of ethmoid which contribute to the bony part of nasal septum, and there is a perpendicular plate of ethmoid, and in continuation it forms the crista galli. And in the horizontal part we have the bony labyrinth on both sides, bony labyrinth with the middle turbinate, superior turbinate, and also the orbital plate. And in the middle meatus, the ethmoid cells open as an anterior group and also the posterior group. And that is the orbital plate, and that is the middle turbinate, you can see there. And coming to the superior view, on both sides comes the ethmoid labyrinth. With the more medially, you can see the cribriform plate. And this is a cribriform plate. And then next, after the cribriform plate, if this is a cribriform plate, then here comes your ethmoid labyrinth, two ethmoid labyrinth, and a connecting with the cribriform plate, there is lateral lamina of the cribriform plate. You got it? So, cribriform plate, from the cribriform plate there is a small lateral lamella. This is a lateral lamella. And then comes the two labyrinth on each side. Okay. And what all things are there in the ethmoid labyrinth? In the ethmoid labyrinth, you can see what is this? This is the superior turbinate. Okay. And this one, this is the middle turbinate. This is the middle turbinate and this is the superior turbinate. And then there are the ethmoid air cells, ethmoid sinuses, around total 5 to 18. And then here comes the orbital plate. You got it? So it has got a vertical part and a horizontal part. Of the vertical part comes the crista galli above and perpendicular plate of ethmoid below. And this perpendicular plate contributes to the nasal cavity or the bony part of nasal septum, and that articulate with a vomer sphenoid from behind and superiorly with the nasal spinofrontal bone. And this crista galli is projecting into the anterior cranial fossa, and on both sides of crista galli lies the olfactory bulbs. And of the horizontal part, the first one is the cribriform plate, which is porous through which the olfactory filaments as well as the anterior ethmoid vessels and nerves pass. And then there comes the ethmoid labyrinth, and connecting the cribriform plate to the ethmoid labyrinth there is a lateral lamella also. And this ethmoid labyrinth contains the anterior and posterior ethmoid air cells along with the superior turbinate, middle turbinate, and also laterally there is an orbital plate which contribute to the medial wall of orbit. Okay, so the superior turbinate and the middle turbinate are parts of ethmoid bone. And what about the inferior turbinate? Inferior turbinate is an independent bone. Okay, along with the maxillary sinus, I told you where this middle turbinate is, the inferior turbinate is situated. Inferior turbinate is an independent bone which articulate with the maxillary as well as the lacrimal bone to form or complete the natural ostium. Okay. So the superior turbinate and middle turbinate are part of ethmoid bone, and of the ethmoid cells or the ethmoid sinuses, a total of around we can tell it as 2 to 200, but broadly it is said as 5 to 18. Okay. So of this there is an anterior group and a posterior group. These cells are again divided into an anterior group and a posterior group. And this anterior group is actually situated anterior to the basal lamella. What is basal lamella? I will tell you along with the middle turbinate anatomy. Don't worry. So just remember, anterior group of hair cells are situated anterior to the basal lamella, and the posterior group of ethmoid hair cells are situated posterior to the basal lamella, and this anterior group drain into the middle meatus, and the posterior group drain into the superior meatus. Okay. The anterior group of ethmoid hair cells drain into the middle meatus, and the posterior group drain into the superior meatus along with the sphenoid sinus. Okay, so the sphenoid sinus and the posterior group of ethmoid hair cells open into the superior meatus, but the frontal, maxillary and the anterior ethmoid cells open into the middle meatus. Okay, so that is about the anatomy of ethmoid bone in general. Two more things along with this is, in the orbital plate may sometimes contain small dehiscences which allow the spread of infection from the ethmoid to the orbit. And on the anteriormost part of the crista galli there is foramen cecum. Here comes it in the superior part, and through the foramen cecum an emissary vein goes from the nasal cavity to the superior sagittal sinus. Okay, that also you have to remember. And coming to the development, this ethmoid sinus is present at birth. It is radiologically visible by 1 year and reaches adult size by 12 to 13 years. Okay, the development is by endochondral ossification. Regarding the named ethmoid cells, they are the Agarnaceae cell, then Hala, Onodi and also the ethmoid bulla. So what is this Agarnaceae? Agarnaceae is actually the anteriormost ethmoid hair cell. Okay, it is very anterior, just anterior to the insertion of middle turbinate. So in a coronal cut CT, in the anterior cuts, you will get the Agarnaceae. Here see, this is Agarnaceae. This green colored is an Agarnaceae, and sometimes this Agarnaceae cells may be very large. Okay, like this. This is very large. So this is the middle turbinate here. You can see the insertion of middle turbinate here starting, and just anterior to that comes the Agarnaceae. And when it is very large, what is happening here? This is the frontal sinus, red color, and actually this is an uncinate process. You know the drainage of the frontal sinus. If you have any doubt, just see my class on frontal sinus. It is elaborately given there. I am not going to the detail of that. So normally this frontal sinus, through the frontal recess, it should drain into the middle meatus. And because here the uncinate process is attached to the lateral wall of orbit. If the uncinate is attached to the lamina, then there is no problem that for the frontal sinus to drain into the middle meatus. Here what happened? Here there is no Agarnaceae, but this is a Agarnaceae cell, this green color. So what happened? This Agarnaceae is very much extensively pneumatized, so that it is blocking the frontal nasal duct, or it is blocking the frontal recess area. So that what will happen? There is blockage of this frontal, this cannot flow without obstruction. So there is blockage of the flow of frontal sinus drainage, leading to a frontal sinusitis or a mucocele or later a pyocele. Okay, so that is the importance of Agarnaceae cell. So Agarnaceae cell is an anteriormost anterior ethmoidal hair cell, and when extensively pneumatized, it can cause blockage of the frontonasal duct or the frontal recess area, leading to recurrent frontal sinusitis. So the treatment is a removal of the Agarnaceae and clearance of the frontal recess area. Okay, and that is regarding the Agarnaceae. And what about the Hala cell? Hala cells are actually, they are also anterior ethmoidal hair cell, but they are seen in more often posterior cuts. Okay, posterior cut. How will it be? Cell, this one. This is the orbit and it is extensively pneumatizing into the floor of orbit. So what happened? Where does this maxillary sinus drain? Here you can see. This is the maxillary sinus and this is the inferior turbinate with the uncinate process here, and this is the middle turbinate. So uncinate process in this case is attached to the middle turbinate. I have explained the drainage of the maxillary sinus with the anatomical details along with my class on maxillary sinus and maxillary bone. So here this is the ethmoid infundibulum, isn't it? So this normal course, this should come and drain into the ethmoid infundibulum, then to the middle meatus. So here what happens? This ethmoid infundibulum, this area is blocked by the Haller cell. See here. So from this secretions cannot drain through the ethmoid infundibulum because of this Haller cell. So that is, Haller cell is an extensively pneumatized anterior group of air cell which pneumatize towards the floor of orbit, causing blockage or obstruction to the ethmoidal infundibular area. So also the maxillary sinus drainage, causing recurrent maxillary sinusitis. Okay, that you will get in a coronal CT scan of the nose and paranasal sinus. So that is regarding the Haller cell. And what about this Onodi cell? Onodi cell is a posterior group of ethmoid sinus which extensively pneumatized around the optic nerve. See, this green color, this is the Onodi cell and this is the optic nerve. Optic nerve, sometimes it will go behind the optic nerve or sometimes the optic nerve will be seen, like in this case, this optic nerve is seen inside the Onodi cell. So what is the complication that can occur? If you are thinking this red is a sphenoid, and if you are thinking that the sphenoid sinus is coming directly behind the posterior wall of posterior-most ethmoid air cell, you can poke and can damage the optic nerve. So never think that the sphenoid sinus always come, anterior wall of sphenoid sinus is always posterior to the posterior-most ethmoid air cell. Always take an tomogram, study the cuts thoroughly and then only go. And another thing is that when you puncture, when you are approaching the sphenoid sinus through the posterior ethmoid, always go as far medially and inferiorly as possible. Your forceps or your instrument tip should be always medially and inferiorly. Never go posteriorly or laterally. That there can be chance of injury if you go posterolaterally, or also you can also injure the orbit also. So your tip of the instrument should always be medially and inferiorly. Okay. So that is about the Onodi cell. And what about the ethmoid bulla? Ethmoid bulla is then constant, most prominent anterior air cell, anterior ethmoid air cell. Okay. The most prominent and the constant anterior ethmoid cell is the ethmoid bulla, or otherwise we call as a lateral bulge or torus lateralis. Okay. Of the anterior group, the most constant one, that is anterior to the basal lamella. I will tell you, explain again when I explain it along with the middle turbinate. So that is the most constant anterior group of ethmoid air cell which lie anterior to the basal lamella. And here this is the ethmoid bulla, this one. Okay. So what is this? This is a frontal recess, isn't it? This is a frontal recess. So this ethmoid bulla is always posterior to the, it forms the posterior limit of frontal recess. Okay. So ethmoid bulla forms the posterior limit of the frontal recess, and sometimes this ethmoid bulla will be attached to the skull base, roof of ethmoid. Okay, in some cases this will be like this, attached to the roof, or in some cases this will form the limit here only. There will be a gap here. Okay. Sometimes this bulla will come and attach to the roof of ethmoid. Sometimes it won't reach up to there. Okay, it will reach up to this line only. So there will be a gap. So gap will be above and also posterior. Okay, isn't it? You got it? Sometime this ethmoid bulla will come and attach up to the roof of ethmoid, this area. Sometime it will stop short of that. In that case, this space is called the lateral sinus. Okay, lateral sinus or sinus lateralis. That is important during a functional endoscopy sinus surgery. Sinus lateralis, this space, lateral sinus. So what are the boundaries of the lateral sinus? Above, what is there here? This is the ethmoid, roof of ethmoid. Below comes the roof of ethmoid bulla, and medially what will be there? This part, this will be the middle turbinate, and laterally comes the lamina. Got it? So you also studied the boundaries of the lateral sinus. Above there will be the roof of ethmoid, below will be the upper limit of bulla or the roof of ethmoid bulla. Medially it will be the middle turbinate and laterally the orbital plate or the lamina papyracea. So these are the special named ethmoid cell. Agar, halar and ethmoid bulla comes along the anterior group, and Onodi cell comes along the posterior group. And Onodi for optic nerve. You can remember in that way. Onodi causing the optic nerve. Halar comes along the floor of orbit, causing obstruction of the ethmoid infundibulum or drainage of the maxillary sinus, and the agonise, the anteriormost ethmoid cell, causing blockage or obstruction in the area of the frontonasal duct area, causing a recurrent frontal sinus. Next is the middle turbinate. This is the middle turbinate, and this meatus comes infrolateral to the turbinate. Okay, this is the middle turbinate and this is the middle meatus. Is there any doubt in that? Always the meatae comes lateral and inferior to the turbinates. Okay. And this spatial orientation of the middle turbinate is a bit confusing. As a postgraduate, I was very much confused about that, and I am sure many of you also, most of you also will also be confused about the different parts and the spatial orientation of the middle turbinate.